Folks, it's Marvin Music with MedicareSchool.com, and we want to welcome you to our live event this afternoon. Grateful that you've made this a priority in your schedule. I normally do these at 5 p.m., but I'm speaking at another Medicare event tonight, so we had to move it to this time slot. So glad you've joined us. A couple things I'm going to mention before I get into my topic. I am going to take as many questions as possible during our Q&A time. So if you have any questions about Medicare or about Social Security, you can begin to put those in the chat right now. I would ask a favor of you, and that is to make sure that you're not so abbreviated in your question that we cannot understand what you're asking. Sometimes people are trying to be, I think, polite and not be too wordy, but they're so concise that we cannot comprehend your question, so I can't help you. So be sure to make sure your question's thorough enough where I can be of assistance. Also, I want to mention that we would like for you, if you have not already have done this, to actually subscribe to our YouTube channel. I know some of you have, but some may not. And the benefit of that is every time we put out new content, which is usually 1 or 2 videos every week, you're notified about that new content. That way you're able to stay up to date on what's happening with Medicare and Social Security. So we'd love for you to subscribe to our channel. Of course, there's no cost to do that. And then if you need any assistance immediately, you'll see throughout this program, there's a toll-free number there. You can actually call into our office. We have agents that can talk to you now. So just call in and then you can get that immediate assistance. And so if that's a need you have, we are actually located, we are, by the way, a nationwide broker. We write in all 50 states and D.C. But our home office is in a suburb of Kansas City, Missouri called Overland Park, Kansas. So we're on Central Time, and so our phone switchboard opens at 7 a.m., goes to 7 p.m., and then on Friday it's 7 to 6. So you can reach us all the way up until 7 p.m. Central Time today. And so we'd be delighted to help you, to assist, answer questions, and really to ultimately serve as your Medicare broker. And remember, folks, when you buy any kind of Medicare insurance, there is no cost to you to use the services of an agent. That's us. That's really anyone. Because the way Medicare insurance works is the insurance company actually is the one that pays us. They do pay us a commission. And so there's nothing out of your pocket to use our services, and we help people all the time, every day, to enroll into Medicare and enroll into Social Security if they want to at the same time. And so we'll go through that entire process. If you're coming into Medicare after 65, your process is different. It's called an SEP, or a Special Enrollment Period. And we can get all that paperwork set up for you so that then you can come into Medicare without any penalties and problems. So just keep in mind, anything that you need, we are happy to assist in that process. All right, so just give us a call, and we'd be delighted to be of service to you. All right, let's talk about our topic tonight. We're going to get into this whole issue of the additional costs that can be incurred and actually will be incurred by certain people when it comes to Medicare. And so let me just give you a little bit of background on this and kind of some foundational information so that you understand. The majority of people today, majority meaning like 99% of all people today that are enrolling into Medicare A are going to get Medicare A at a 0 premium. In our business, we're told not to call it free, because it's really not free, because you've been paying for it all your life. As we work, all of us are paying FICA taxes, or if you're self-employed, we pay self-employment taxes. And so we are funding Medicare. We're also funding Social Security. And so the Medicare portion that we're paying is 1.45% of every dollar that we make is going into Medicare. And your employer is matching that. So 2.90% goes into the hospital trust fund. Now, if you're high income, what happens? High income by Medicare standards for the Medicare taxes is for a single person, anybody above $200,000, married couple, anybody that's files a joint return above $250,000. If that's your case, all the amounts of money above that, you actually pay an additional 0.90%. Now, the employer doesn't have to match that, but you would actually have to pay that. And so my whole point is that we are funding Medicare A through payroll taxes, FICA and self-employment taxes. And so when we go on Medicare, whatever age that is, 65 or 67 or whatever, we actually get Medicare A at a 0 premium because, again, we've already really paid for it. And so that's the way A works. Now, B doesn't work that way. B is not based upon the Medicare taxes and quarters that we accumulate. It's actually based upon our income. And so if someone is on Medicare in 2025, the income number that the government is going to look at to establish your Part B premium is your 2023 modified adjusted gross income. We use the acronym MAGI, modified adjusted gross income, and it's always 2 years prior. So this year, anyone on Medicare, the government looked at 2023 modified adjusted gross income. And if you're unfamiliar with that, it's very simple. It's line 11, which is AGI on your tax return, plus line 2A. Line 2A is where someone that has tax-exempt interest would report that number. Tax-exempt interest typically comes from municipal bonds as well as some U.S. savings bonds. And so the interest income off of municipals and U.S. savings bonds at times are not federally taxed, but you still have to put that number on your federal tax return. And that's where line 2A comes into the picture. Tax-exempt interest is added to our adjusted gross income, line 11, and that's the number Medicare uses to establish how much it's going to cost you to be on Medicare Part B premium. And so most people, the average person today, is paying what we refer to as the base premium or the standard premium, and that is $185 a month. That'd be per person. So if husband and wife are both on, each of you would pay $185. If you're a single person, you pay $185. And so as long as your modified adjusted gross income in 2023 is below the thresholds that are established by Medicare, and these thresholds change every year, but this year the thresholds for a single filer is $106,000. So if they look back at 2023 and they see that your modified adjusted gross income is below $106,000 as a single filer, you pay only the base Medicare B premium, again, $185 a month. If you're a married couple that files a joint return, that number is doubled, so it goes to $212,000. So as they look back at 2023 and you are at $212,000 or below modified adjusted gross, each of you, husband and wife, on Medicare would pay the $185. All right, so that's a standard base premium. And so what happens is these numbers, the thresholds, as well as the Part B premiums, are reset every year. They reset every January. So we have $185 this year. We have the thresholds that I just shared with you. But if someone is going to be above the thresholds, above 106 as a single filer and above 212 as a married filing a joint return, then they're going to pay an additional amount. And that additional amount is, it's called an IRMAA. It's an acronym. IRMAA stands for Income Related Monthly Adjustment Amount. Income-related monthly adjustment amount. So those people that are considered to be high income are going to pay more for their Medicare Part B premium above the $185, and they're also going to pay more than just a drug premium. They're going to pay a surcharge for their drug plan as well. So anytime we have a B IRMAA, we're also going to have a D IRMAA. And those IRMAAs, of course, are recalculated on an annual basis. And so this year, what we have, anyone above 106, or above 212 as a couple, we have 5 different levels of IRMAAs. You can almost look at these as kind of like marginal tax brackets. Marginal tax brackets work, the more income we make, the higher amount of taxes we're responsible for marginally. And so we have these 5 brackets of IRMAAs. And so if you want to look at this exact chart, you can, of course, Google it or use some search engine and look at the different IRMAA brackets. And so there's 5 of those. And so the first IRMAA bracket, and this would be someone that's a single filer, and they're between 106 and 133. Or a married couple between 212 and 266,000, that very first IRMAA bracket has a B IRMAA, an additional charge of $73.60 a month. And on the drug portion, that IRMAA is this year $13.70. Now, I'm not going to go through every one of these. I'm just trying to show you at that first level of IRMAA, that combined surcharge is right at $87 a month. So if we're in that income bracket, first tier for IRMAAs, you're going to pay an extra $87, and this would be per person. And so the point is, Medicare costs you a little over $1,000 more a year because of your high income. The second bracket, you would pay an additional $2,600 a year for your B and your D IRMAAs. The next bracket, you would pay over $4,200 extra a year. And then the next one's $5,800 a year. And then the highest one is a little over $6,300 a year. So again, it's $1,000 and then about $2,600, then $4,200, $5,800, and $6,300. And again, this would be per person. Now, that highest bracket is for singles that make above $500,000 and for married couples that are above $750,000. A lot of people are not going to be at those kind of income levels, but many of you are going to be above the initial threshold. So you're going to have an IRMAA for B and D somewhere between $1,000 to $6,000 on an annual basis. Now, I tell people all the time as I teach about these, frankly, this is a good problem to have. Listen, I pay a lot of taxes too, and I know all taxes are disappointing, but it's just the way it goes. And there's really nothing that can be done about that. If your income's up, it's a great problem to have. You're just going to have to pay more for your B and D. I know that doesn't give you any help other than to say it's nice to have that extra income, but it will cost you more to be on Medicare. But there are times when people have what we refer to as a life-changing event where they have a marriage or a death or a divorce, or they semi-retire or fully retire, and they have a life-changing event that affects their income. So we know the government is automatically in 25 looking back at 23. But what happens if you retired in 2024 and your income's less than it was in 2023, or you're retired in 2025? And so if those numbers change, what you can do is you can appeal or ask for a reconsideration of the IRMAA. And again, we have one of 8 life-changing events: marriage, death, divorce, work stoppage, work reduction. And there's 3 more that, frankly, I've been in this business for 16 years. I've never even used these 3, but one of those is a loss of income-producing property. That means that you had a property that produced income in 2023, but it burned down, or it went down a mudslide, or it was destroyed in a flood. You no longer have it. Or there's one that is a loss of a pension income or an employer settlement agreement. Again, I've never personally helped someone with those, but that just means that you had this pension income, this employment settlement income in 2023, but you don't now. And so as long as we have proof that we've had this life-changing event, one of the 8, then we can ask for a reconsideration. The paperwork that you would fill out, and by the way, if you're our client, we'll walk you through this whole process, but it is called an SSA, Social Security Administration or Social Security Agency, -44. Okay, Social Security SSA-44. It's actually a 9-page document, but you only have to submit the first 3 pages. And all you're simply doing is saying, you all are looking at 2023, but I've had this life-changing event, so you check the box of which one it is, and then you can give them different numbers. You can give them last year, you can give them 2024, or you can give them 2025. You can even project. You just want to be accurate. Okay? And so now that life-changing event has to be in the past. It can't be, hey, I think I'm going to semi-retire, or I'm going to retire. It didn't work that way. You actually have to, that event has had to happen, and we can actually use that life-changing event 2 years. Since they automatically look back 2 years, they give us the chance to use that same event for 2 years as well. And so that's called a reconsideration or appealing of the IRMAA. And as long as your numbers are accurate and it's within the last 2 years, you will win that appeal. You just will. And they'll drop those IRMAAs off. They don't want to hold you accountable to 2023 income if that's not the reality. But if your income stays up, you're just going to simply have to continue to pay the additional surcharges. Okay? And so as we talk about the highest one again, a little over $6,300, the lowest one about $1,000. And again, this affects about 15% of the population. And so if you're impacted by that, be grateful that you have the income. And if your income changes, then take the time to appeal that and ask for a reconsideration and get that IRMAA reduced. My last comment I want to make is this. Sometimes we'll have people that are very high and they have a very high IRMAA, and their income is going to change because of one of these life-changing events, but maybe it doesn't go all the way down below that bottom threshold, but maybe their income moves a couple of levels. Folks, it's still worth your time, even if you move down one IRMAA level, to go ahead and appeal that. So take the time to do that. Hopefully, you maybe eliminate all of it, but if you can't, then at least eliminate some of the IRMAA charge. All right. And so if you have any further question about that as we get into the topic, I'm happy to answer those as well. All right. So Daniel's our producer for our channel, and he's with me in studio, so he's going to actually feed me the questions. And so let me know what's on your heart, and I'll do my best to see if I can give you some direction.
Okay, this is a two-parter, so we'll start with this.
All right, so Ronnie says, my Medicare Parts A and B are effective as of June 1, 2025. As I'm turning 65 in June, I received the Medicare card reflecting A and B. Both have same effective dates. Very good. Also, I have TRICARE for life effective June 1 as well. Would there be a time when I would need Medigap with the G plan? Can I afford it, but is it necessary? Now, Ronnie, my suggestion would be not to get a Medigap policy G. Now, I love G plans, and I think Medicare supplemental plans are awesome, but you don't need it. It really would be, in my opinion, a waste of your money. So you do have A and B, which will now be the first payer as of June 1, and then TRICARE for life, which it becomes once you're Medicare eligible, is going to pay second to Medicare. Now, I do know that there are some people in your position, TRICARE, not all, but some, that actually will enroll in what is referred to as an MA-only plan. It's a Medicare Advantage only, meaning it does not have prescription drug coverage as a part of that. Those are MA-only plans. And some people in your position will do that because they like some of the perks that are offered by Advantage plans. And TRICARE agrees that they will actually coordinate your healthcare benefits and services with the Advantage company or with A and B. Either way, they'll coordinate, and you should not have any out-of-pocket expenses either way. So then why would someone on TRICARE do this? Well, they may like the gym membership benefit with the MA plan. They may like, the little vision allowance or the dental allowance that comes with these. Also, many of these MA-only contracts will give you a reduction for your Medicare Part B. Right now, everyone's paying $185, as I just talked about, unless you're high income. And so some of these MA-only plans, the insurance company will offset at either $150 to $175 a month of your Part B premium. And so that's a nice benefit. And so the point is that if you enroll in that plan, because that Medicare Advantage company is not responsible for your drug cost, they actually then give you a credit towards your Part B premium. And so, because you're going to continue to get your meds through the TRICARE insurance, it's a credible coverage plan. So you'd have an MA only. And one of the nice things about people who go with this MA only plan with TRICARE is that it's not a lifetime decision. You may try that, and if you don't like it, then any year during Medicare open enrollment, you can actually drop the Medicare Advantage plan and return back to original Medicare A and B and have your TRICARE as second. But my point is TRICARE will coordinate either with A and B or it will coordinate with the Advantage plan. So if you find in your area a Medicare Advantage only plan that's attractive, offers some perks that you like, and as well as gives you the Part B give back, that may be something you may want to consider, but would not do a supplemental plan. Okay. All right, is Plan Z the same throughout the country except for the cost? And yes, it is. And the reason for that, James, is because all the supplemental plans are called standardized plans. And that means that Medicare sets the rules for what bills are paid and what bills are not paid based upon the letter that you buy. So they're standardized. So if you bought a G plan, and I'm just throwing out some names from Aetna, from United Healthcare, from Mutual of Omaha, from Cigna, from Humana, whoever you bought a G plan from, and regardless of where you live, everything is going to be paid except the Medicare B deductible. The G plan is the most comprehensive plan available today. It covers all the Medicare gaps except one, and that's the B deductible, which resets every January. And so regardless of where you are, what company you go with, those G plans are identical. Okay, cost, you're right, it will vary state to state and carrier to carrier. All right. Okay, Karen, hi, Marvin. Again, Walgreens RX won't bill Medicare B or my G plan for, okay, why can't they bill properly? Well, I think what's happening is a lot of times in these pharmacies, the staff, they're not trained well enough, or they don't slow down long enough to realize that these glucose monitors are actually being paid through the Part B of Medicare instead of the Part D. The majority of business being done at the Walgreens pharmacy, they're running these things through D plans, drug plans, prescription drug plans. And so as they go through that billing process, they give the D number and send the bill that direction instead of your Medicare number. Now, let me tell you what I tell people to do, Karen. I would actually use one pharmacy for my regular prescription meds. That's my D plan, and I'd go to a different supplier to get anything else that's going to be paid through Medicare B. That way I don't have that confusion. So that way, let's say I'm just making this up, you go where you want, but if let's say you went to CVS or you went to whoever, and you got your Part B durable medical equipments and different supplies that B is going to cover, then you're not going to give them your drug card. You're only going to give them your A and B card and your supplemental card. That's all you'd give them. And they get your prescriptions elsewhere where you give them the D card. And I'm not saying that's the only way to solve the problem, but that's the way I would go about it, and hopefully you could see some success in that way. I mean, again, what your complaint, your problem, it's sad, it happens, but it's not uncommon. It's just, you're really just the competency level of some of these people that work in these places. All right, so wish you the best on that one, Karen. Okay, Candy, is it true that domestic partners on their credible insurance are not qualified for a special enrollment period, so required enrollment exactly right? Now, I want to say this, Candy. I have checked into this before, and so what you said is true. Domestic partners do not qualify as active employment, and therefore for an SEP based upon your coverage at work. That is true. Now, there could be some states where there may be exceptions. Remember, because the federal law sets the rules, but some states can make those a little bit more friendlier for the consumer. But as the general rule, the federal law is that insurance companies and Medicare do not have to give you an SEP if you're getting coverage through a domestic partner. That is very true. I'm cautious here because there may be one state that they have their own rule for this. But unless you can find that there's a state that does that, then you need to make sure that your domestic partner is going on Medicare during the initial enrollment period, because they will not be eligible for that SEP. All right, is supplemental insurance considered Medigap coverage? Yes, it is. They're identical. They're just synonymous words. Some people call them supplemental plans, some call them Medigaps, but they are the same. All right, I have A, B, and G. Do I need a referral to see a specialist? No, you don't. Plans that require referrals to see a specialist are Advantage plans, and specifically HMO Advantage plans. But within the system of Medicare, Medicare does not require that you see a primary care to see a specialist. Now, I would say this, though, you all. I have seen from time to time that there are certain specialists that just the way they do business, they will not see you unless you have a primary care doc refer you, because they really are not trying to establish a relationship with you. They want your relationship to be with your primary care doc. So a specialist could add that rule, but it's not a Medicare rule. It's not a supplemental plan rule. But I have seen a few times, and I mean rarely, but it still happens, where a specialist says, no, I want a referral from your primary care doc. But Medicare didn't mandate, nor the supplemental plan did not. That's the one that I had lined up. Hey, that's all right. Daniel's finding another question. Here we go. Hector, when do you apply to eliminate the IRMAA? I'm enrolling in Part B. I made above 106 in 2023, but I lost my job then in 2024. Can I apply to qualifying event, work stoppage during IEP or after? Okay, Hector, it's real simple. Once you apply for Medicare, you are going to get an initial letter letting you know that they have your enrollment. And you'll probably get a very generic form letter saying that your Medicare B is going to be $185. That comes usually within about 2 weeks, sometimes 3 or 4 weeks of enrolling into Medicare. And then about 2 to 4 weeks after that, you get a second letter. And it basically says, hey, by the way, Hector, we heard from the IRS that you made X amount of dollars, and you were above the 106, and so you're going to have an additional surcharge called an IRMAA that you're going to be responsible for. However, if you've had one of these life-changing events, then you can appeal that and ask for reconsideration, and we will consider that. Okay, so my point is this. 2 things have to happen. You cannot appeal an IRMAA until you get the IRMAA letter. You can't, so you've got to wait for the letter. And again, it won't be forever, but you have to wait a little bit. And then second is you have to make sure that your life-changing event has also been in the past. And of course, it has because of 2024. So when you make that appeal, once you get the letter, you can give them 2024 income, or you can give them 2025 income. It doesn't matter. You can even project for this year. And so as long as you fall below that 106, you eliminate the IRMAA altogether. Okay, so that's the process. All right, my husband is really a good insurance, which I'm covered under $240 a month. Am I better off staying with his insurance after I turn 65 or additional B, C, D, or G? All right. Well, Joanne, it just depends. If you have a good insurance plan, I'm happy with the premium. I think 240 is kind of the cutoff. I tell people anything above 250, Medicare may make more sense. But at 240, that's good. But I would also want to find out what's your deductible, and do you ever meet that deductible? Because you may have a $1,500 deductible, or $2,000 or $3,000, whatever. You have some health problems going on, you may reach that deductible. So if it was, let's say, $2,500, you divide that by 12, that's over $200 a month just for deductible. So we take the premium you're paying plus the deductible amount, and all of a sudden now that plan does not look as real attractive. Now, let's say the deductible is $1,000 or less. Well, then that still may be a pretty good option. And so I think with this, it's something that you may want to keep, but I still would take the time to compare what your Medicare options are. I just wrote a couple out of Phoenix yesterday, and they both got G plans, and they were about $125 a month. And they were also on a drug plan that was zero. So you take $125 for a good G plan that has a B deductible of $257. You take your $185 for your Part B, that's a total of what, $310 a month for their plan, and they have a $257 deductible. So again, you have $240 a month, so it just depends on how high that deductible is, and are you meeting that before I'd really make that final decision. And again, I'm not saying every state's going to be like that. So Arizona has very attractive rates, but I still would take the time to compare it if you have a high deductible. You call us, and if you have that high deductible, then we can go through and give you some exact prices for your area. Okay, but it's a good plan. I mean, I like 240. That's wonderful, but I'd still take the time to compare. All right, let's keep going. Scott, is there any time a doctor, et cetera, takes Medicare and you still wind up with a charge with a supplemental plan and you have met your deductible? Okay, well, the only way that could happen, Scott, would be if you went to a doctor, a primary care doctor or a specialist or a surgeon that charged excess. That excess amount is 15%. Now, it is pretty rare that we see excess anyways. They say right now that 95% of all doctors do not charge excess. So only 5% do. So that could be a way that you actually could get a bill from a doctor beyond the deductible. Another way that you could get that, pardon me, I'm sorry, is if the billing process got a little bit delayed or something, meaning you've already met your deductible, but you still get this bill. Number one, don't pay it unless it's excess. Now, if you have a G plan, it covers excess anyways, but N plan does not. So if you had an N plan, you could get an excess charge. So if neither one of those are the cases, then I would just say don't pay the bill, and then call the provider and say, I know why I'm getting this. My insurance company is responsible for everything but my deductible. I've already met it. And then you can also call your insurance company because, hey, you're their client, or call us if you're our client, and we can make sure that there's no billing errors there. And that's probably what's going on. It's just a billing error. Something went wrong, but you ought to be able to call the insurance company or the provider and find out what's happening. Why are you still getting that bill? Okay. All right, Ron, hi. We have a house in New York and a weekend place in Pennsylvania. I see huge price differences of programs between states. I've heard that New York doesn't allow prescription plans. Okay, well, first off, I'm sorry. Are there any special requirements I need to meet in order to get supplemental and drug in Pennsylvania? Okay, well, here's officially, Ron, the way it works. You are supposed to get a supplemental plan in the state that you reside in the most, which would be 6 months and 1 day, okay? And so if it's kind of split between, and you can have a good conscience about saying, hey, I want to buy a plan in Pennsylvania, that's fine. Just know that you're going to have to be able to receive mail there, because what happens if you're getting all your mail in New York, then you could put on your forms, you have a different mailing address. But if you ever do a change of address and make New York your official address, then that's going to pose problems for you, because when people move and they do a change of address, the Postal Service actually notifies Medicare, because prescription drug plans and Advantage plans are going to be tied to that particular area. All right, so you just got to be careful about that. I've seen people kind of mess that up a little bit. So as far as your question, any special requirements? No. Now, and by the way, you said something about no drug plans in New York. I've not heard that. Is that what he said in that first part of the question? And Ron, that's news to me, and I'm sorry. I did not know that New York didn't allow prescription drug plans. I do know that they don't allow excess charges. I think you can actually have excess up to 15%. I mean, up to 5% in, say, New York, but most of them are. Yeah, I just never heard of that. I'm sorry. I just never heard of a drug plan not being available. So that's something we can check into. Doesn't make any sense to me. Drug plans should be available in all 50 states. So you need to verify that for sure.
Yeah,
Okay.
are available.
They are. Okay, I thought they would be. And you're right, there are differences between Pennsylvania and New York. Your prices are going to be much better on supplemental plans in Pennsylvania. So if you can, with a good conscience, say that's where you spend 6 months and a day, then you actually can get your supplemental plan rated there in Pennsylvania, and that's fine. Okay, and then get a drug plan there as well. All right, let's keep going. Okay, I'm 70 years old, working, have employer insurance, 400 employees at Part A. What should be my plan to switch to Medicare as I can continue employer's insurance, in retirement, and it will be paid? Okay, well, what's going to happen when you do officially retire, if you're able to keep your insurance plan from work, it still will move to the second payer position. So once you're retired, whoever that is, whoever the insurance company is, they are not going to pay first, I can assure you that. So what you're going to do, I would say about 60 to 90 days prior to your retirement date, where you're going to lose the group plan, then I would set everything up for my Medicare B. That's called an SEP, special enrollment period. And then once you've lost your group plan, let's say that happens, August 31st. So you would request a B date to start September 1, so that A and B pays first, and then that retirement plan is going to be in the second payer position. And that's fine. You also want to make sure that they have a drug plan included. A lot of them do not, so you may have to buy a separate drug plan, which is not a big deal. Those will be available for you to do that. So 60 to 90 days prior to losing the coverage is when I would set that up, okay? But you do have to set it up. I promise you, your retirement plan will not pay first. It'll be second to Medicare. All right, Daniel. Here we go. My husband is on disability with Medicare A and B. Will turn 65 in October. I plan to drop him off my work insurance in January 2026. Do we need to do a new sign-up for Plan N and add Medigap plans? Okay. Well, my first question is, you say a new sign-up. Are you saying that he already has an N? Because if he already has an N, then you don't have to. That N is a policy written for life. But it doesn't sound like he has an N. Your word new is what threw me off. So I'm going to interpret this way, Carol, that he just has disability, Medicare because of disability. And so he turned 65 in October, so November, December. So what I would do is you have a 6-month window from his Medicare B date, which will be October. And you have a 6-month window where he does not have to medically qualify. So I would keep him on your work plan. I know he's going to have A and B in October. I'd let your work plan continue to cover through December 31. Then January 1, I would make his Medicare Supplement Plan ineffective. You're fine to do that. There's still no underwriting, no requirements whatsoever. It's a 6-month window once we start Medicare B, where you can get any supplemental plan that's sold in your state. All right, so that's what I would do. And so you can add that plan, probably start shopping and make that decision during the month of October. You're going to need a drug plan as well. And so I would do that anytime after October 1. But I still would request everything to begin January 1 of 2026. And so A and B will pay first, N's going to pay second, and then he has a drug plan, and both the N and the drug plan can be effective 1/1/2026. So that's the way I'd go about that. All right. Before you meet your deductible for Part B, do you pay the doctor office directly before leaving their office or wait for a bill? Yeah. You do not pay at the provider's office. You do not. You just give them your cards, your A and B card, your G or N card, whatever you have, and then what happens is the provider is going to send the bill to Medicare. Medicare is going to say, well, you have met your B deductible. They'll still send the balance over to the supplemental company. Supplemental company is not going to pay that B deductible either. And then they'll send it back to the provider saying this $70 bill, $80 bill, $150 bill is applied to deductible. Then that doctor, that provider will bill you, and then you pay them direct. But it has to go through that full cycle, okay? It's just the way the system works. The only people who have to pay something at time of service would be people that are on Advantage plans. If they have a copay, they pay that at point of sale. But you never will at all. If someone asks you for that, just say, hey, I'm on a supplemental plan. It didn't work that way. So don't pay them until later. All right, thanks. Good question. Psych nurse, I'm unable to go online for my Social Security account. Will SSA send me a billing for first month or give me option to create a monthly payment? Okay, so okay. Will SSA send me a bill for first month or give me option to create a monthly payment? So I'm a little bit confused here. You must be talking about Medicare. Okay. So, all right. So what's going to happen is if you're on Social Security, then your Medicare Part B premium, that $185, is going to come out of your check. And so I'm assuming you know that and that you're probably not on Social Security yet. So what will happen, you will get a direct bill from them. And let's just say you're going on Medicare July this year. They'll send you a bill during the month of June. It'll be due June 25th. Now that first bill you get could be as low as 2 months. It can be as high as 5 months. It's just kind of like the lottery. And when you enroll, you get a 2-month, 3-month, 4-month, or 5-month first bill. And then after you paid that first one, then it is on a quarterly basis. So again, 2, 3, 4, 5 months, the first one, it'll be due the 25th prior to the month of coverage. And then after that, it'll be on a quarterly basis. Now, if you don't want to be concerned about paying it quarterly, what can happen is with that first bill, they'll send you different payment options. And the most popular one is a program called Medicare Easy Pay. And you can enroll online, and what they'll do, instead of direct billing you quarterly, they will actually do a bank draft on the 20th of each month. And so that's a very good system called Medicare Easy Pay, and they'll give you instructions as to how to enroll in that program. You can also go on and create what is called a mymedicare.gov account. That's right, you don't have online access, so forget that one. So yes, you'll be billed directly, but you can set up an auto pay with them, and then once you decide to take Social Security, they'll turn off the auto payment and start taking it out of your check. Okay, what about having to sell your home and move to assisted living? Can that be appealed? Okay, well, number one, selling your home is not one of the life-changing events. However, Loretta, the government has some rules where you may not have to report the profit of a sale of a personal residence as long as they call it an exclusion. So Loretta, if you're single, that exclusion is up to $250,000 profit that you made on that sale that you would not have to report as income. Now the rules are, in the last 5 years, you had to own that home for at least 2 years, and you had to occupy it for 2 years. Now those don't have to be the same. You could have lived in it 2 years as a renter, and then bought it in 2 years you owned it, okay? But 2 of 2. So 2 years own it, you got to occupy 2 years, and it has to happen in the last 5 years. And so if that's the case, you qualify for an exclusion, and then that profit up to $250,000 does not have to be reported as income. So that's not going to affect your IRMAA. If you're married filing a joint return, then it's $500,000 that would be excluded. Now, any amount above that certainly is going to have to be reported as income, and it will not be able to be appealed for that. It's selling a home is not one of the life-changing events. But hopefully, if you're below those thresholds at $250,000 or $500,000, that'll be excluded from your taxes anyways, and may keep you from an IRMAA. All right, Chris, how do I keep my VA drug coverage and avoid having to enroll in a Medicare drug plan when I enroll in a Medicare later this year? Okay, here's the way it works. As long as you're already getting your medications through VA, it is considered a credible coverage plan. So when it comes time to go ahead and start your Medicare, if you get a supplemental plan, you will not be required to get a prescription drug plan. And then let's say down the road, the VA changes something or you become unhappy with them and you want to pick up a drug plan, you can always add a drug plan once a year, October 15th to December 7th, and then you'll have to prove that you've had credible coverage, and the VA will do that for you, and then any kind of penalty would actually be dropped. So you're in a fine position. You don't have to do anything. Just don't opt for a Part D plan. Use your VA benefits, and then again, if you have to go back in, then VA is considered credible coverage, and it's easy to prove then if you did want to pick up a Part D plan in the future. So you're fine. Do nothing at all. Now, if you get a Medicare Advantage plan, what I would suggest is get one of those MA-only plans. Don't get an MAPD. Don't get one that has prescription drug plan included, because you don't need it. You're not going to use it. So what you should do, if you do get Advantage, do MA-only so that you can get that Part B reduction from the Advantage company, which is very, very nice in some areas. I mean, literally $150, $175 a month towards your Part B. That's a very good option that a lot of people that have VA will actually use. Okay, let's keep going. All right, 67 till work, still working full-time. Have an appointment with your Nico. Good. Nico's a great guy, really a real pro agent, too. Soon to set retire date, 8/1, since I'm drawing Social Security check this year. Plan A now, getting B, G, and D, but it can be paid auto-deduct with Social Security. No. The way it works is, of course, your A is going to be free, you know that, zero. But the B will come out of your Social Security check. It has to happen. But your G plan cannot. The government will not collect supplemental plan premiums for insurance companies. So that will actually be some kind of a bank draft. Or if you do a direct bill, it's usually quarterly or semi-annually or annually if you want. Most people just pay with a bank draft. And by the way, I recommend that. It's pretty much a flawless system, but I recommend it because you can count on it. Because what happens with supplemental plans is as long as you're paying your premium, it's a lifetime policy. But if you ever fail to pay your premium, they only give you 30 days of grace, and then they cancel a policy. And so if you have a bank draft, there's really no risk of that policy ever being canceled as long as you have the money in the bank. So that's why I think bank drafts are good. The D plan now, that can come out of your Social Security check. I would tell you this, though, and Nick would share this with you. It does take about 60 to 90 days for that to be set up with Social Security. So we always tell people, if you opt to pay your drug plan through a Social Security deduction, be sure if you get a bill that you pay it, because again, sometimes it takes a couple months for that to all get set up. All right, and so A is zero, B's coming out of Social Security, G cannot, and D could if you want. Now, we have a lot of people that are just on very low-cost drug plans. I wrote one yesterday, $3.15 a month. I wouldn't have that come out of my Social Security check. When I got the bill, I'd take the remaining months for the year, let's say it's 8 or 9 months, and cut a check for $3.15 times the months and send one check in, you're done for the year. So I would set that up on a direct bill if it were me. Now, if you had a drug plan that's $95 a month or something, that may be a little bit different. But if they're low cost, I wouldn't have them in my Social Security check. I just pay it direct. All right. Thanks, Jody. All right. Just now enrolling in A and B, job loss in January 2025, so income is less than 2023. Is a reduction in IRMAA possible as I am getting started? Yes, it is. So you lost your job this year. And so they're automatically going to look back at 2023. So wait until the IRMAA bill comes and then do a work stoppage or work reduction, whatever. You decide to go back to work and work part-time, but work stoppage, check the box, and then let them know what you believe your income is going to be for 2025. They won't look at 2023. They'll look at 2025. And if your income is less, then the IRMAAs can be dropped fully or partially, depending upon what you're projecting 2025 to look at. Okay. All right. Hope that helps. I will be 67 soon, have reached full retirement age. If I take my Social Security benefits while still working, would the two incomes be counted towards my IRMAA or just the income from my place of employment? No, all income is counted towards your IRMAA. However, keep this in mind, when you look at the line that's above line 11 that talks about Social Security income, there's a line there that says Social Security income that's not subject to taxes. Because remember, none of us pay taxes on all of our Social Security income. No one does. Some people's Social Security income If they're a single filer and they're below $25,000 a year, or married and they're below $32,000, zero of their Social Security income is taxable. So they wouldn't even have any reportable income for Social Security. Now, if you're single and you're between that 25 and 34,000, then 50% of your Social Security income is taxable. If you're above the 34,000, then 85%. My point is, whatever percentage of your Social Security income is taxable, that is going to be counted towards your IRMAA, because it's going to be in the line where they're counting all of your income, right? So hopefully that makes sense. So that's called provisional income. And so once you know what your provisional income, how much of your Social Security is subject to taxes, then that's going to be a part of the IRMAA total, okay, the total income, which will then determine if you have an IRMAA or not. Hope that made sense. In my brain it did, but hope it did to you as well. Thanks. All right, can we keep Plan F? Absolutely. If you have a Plan F, it is lifetime. In fact, the insurance companies can never cancel any supplemental plan except for non-payment of premium. As long as you pay your premium, that Plan F, G, N, whatever you have, is yours for the rest of your life. They can't cancel it because of age. They can't cancel it because of claims. You know, maybe you're sick and have a lot of claims. They can't cancel for that reason. Can't cancel because you relocate. It's truly your plan for life. Now, I would tell you this, if you can qualify to move to a G or an N, I would certainly look into that. And the reason for that is because you're probably paying at least $50, sometimes $100 more on that F plan than you would for a G or an N. And so what are you getting out of it, especially if you just look at the F to G? F covers all gaps, G covers everything but one gap, that's $257 for the whole year. So if you're paying, $30, $40, $50 up more a month for that F plan, you're paying too much for that one small benefit of a B deductible being covered. Daniel just put up on the screen here, if you want to look at the prices on that, you can see that they're metagapcompare.com. This is a company that we're a part of. A website's excellent, where you can go in there and you can look at all the Medicare supplemental premiums in your area, the different plans that are available, Medigap Compare, and then you can see, what you're paying for your F, find out what you can get on a G or an N. Now, you're probably going to have to medically qualify to do that. And so if your health is, real bad, you can't qualify, then just keep the F. But if you could switch, it doesn't hurt. You'll save the money, and plus you'll start all over with a new group, a younger group, healthier group, and so your rates will probably be more stable as well. So that's what I'd recommend. All right, Marvin, I have an Aflac cancer and accident policy I kept from an employer. Would it be wise to cancel both when I enroll in Medicare? The quarterly premium for both is $123. Well, I think it's fine to keep those. The Aflac plan and the accidental policy, they would be paid directly to you. We call those indemnity plans. You get, if you got cancer, then that Aflac, let's say you had a cancer diagnosis, prostate cancer or whatever cancer, you may be a lady, so let's say breast cancer. If you got that diagnosis, that Aflac policy is going to cut you a check for $10,000, $20,000, $50,000, whatever it is. And so that would give you some additional money to pay for things that you may want. Maybe you want to try some naturopathic things, or you wanted to travel somewhere to get care. So you can use that money for the cost of your care. You're not going to need that money for the cancer treatment, because Medicare is going to cover your radiation, your chemotherapy, your surgery, so they're going to cover you very, very well. But that extra money may come in handy, especially if you're still working, loss of income. So there may be, that cash, that pool of cash may be helpful for you. The accident policy, of course, I'm not sure how that one works. But again, Medicare is going to cover you well on anything medically necessary, but these policies just pay in addition to that. So $123 quarterly, it's not a whole lot of money. If you feel like, especially on the cancer side of it, if you got a nice lump sum amount, what is it? I think half of all cancer diagnoses today, new ones, are people that are on Medicare. So there's a higher likelihood of getting cancer, at our age than it would be, younger. So that may be something that if you're concerned about, you go ahead and keep it. If it works in the budget, if it doesn't, get rid of it, because you really don't technically have to have it. I'm just saying it may be a blessing if indeed you had that cancer diagnosis. All right, let's keep going. Okay, how far back can you backdate Part B coverage services? Currently do not have Part B coverage, but we'll be getting it soon. Yeah, they're not going to backdate Part B ever. Now, I will tell you this. Let's suppose that we applied for Part B today, and it's, what is today, 17th of April. Yeah, 17th of April. And we requested a Part B effective date for 5/1 of 2025. But let's say you're in an area where they're behind in processing applications, and they don't actually get to you until, let's say, June 4th. Well, they're gonna backdate your B to 5/1 because you applied during the month of April. You requested a 5/1 date. So in that regard, they're going to backdate. But if you applied today, or applied for Medicare B 417, and you requested a 3/1 start date, that's never going to happen. In fact, you can't even today request a 4/1 start date. We can request one in advance, and if they're behind, then they'll backdate. But again, they're not going to backdate your B date. So you need to get moving on that. Okay. I will. Well, of course, I don't know all your situation. You may be in a very unique situation where you may have even missed your opportunity if you've waited too long and you only qualify for what's called a general enrollment period. Then that just ended March 31. So we have 3 enrollment periods. We have IEP that we use to start Medicare at 65. We have an SEP that we use within 8 months of losing our employment coverage. That's an SEP. So if we don't have an IEP or an SEP, then we're eligible for a GEP, general enrollment period, but that's just the first quarter of the year. And so we're out to that. So if you don't have an IEP or an SEP eligibility, you're not going to be enrolled in Medicare until the first quarter of 2026. So I hope that's not your situation, but that's the way it works. All right, let's keep going. I turned 65 in August. When do I need to start looking at these plans? Well, let's back up the clock. July, June, May. Really, any time now. We can actually begin to enroll you effective 3 months prior, so that would be the month of May. We could go online and help you enroll into Medicare A and B. You can select your supplemental plan, your drug plan, your Advantage plan, whatever insurance you select. So you're just within a short period of time. And I would say this: if you're going to use our company, call in right now. Call the 800 number. We have agents that take live calls, and they could, you can do everything right now in order to be able to get you into Medicare. It's normally about 90 days prior, but that system for an August 1 start date will probably be open now because anyone that's on Social Security that is automatically enrolled into Medicare, of course, then they're getting their Medicare cards right now. For August 1 start date. So you should be able to self-enroll as well. And again, we'd help you with that. Give us a call. We'd love to be your broker, and there's no cost to use our services. All right, what is the difference between Plan N and G? A couple things. One is the premium. The G plan is more comprehensive, so it costs a little bit more. N plan is still a very good plan. It's a little bit cheaper. And it really depends, Gary, where you live. Like in our area, I live on the Missouri side. Our office is in Kansas. We're right on the state line. But in our area, the difference between G and N premiums are in the neighborhood of about $30 to $40 a month. And so premium's different. Number two, the G plan covers a little bit more than what the N does. N is still a very good plan, but the G covers 5 of the 6 Medicare gaps, 5 of the 6. The gap that the G plan does not cover is the Medicare B deductible. It's once a year deductible. This year's $257. So when someone has a G plan, they basically have full coverage other than the once a year B deductible. Someone has an N plan, it covers 4 of the 6 Medicare gaps. So the N will not cover the B deductible, just like G didn't, that $257 once a year this year. And then it will not cover excess charges if and when they occur. Excess charges are very rare. 95% of doctors do not charge excess, 5% do. And so there's a 5% chance, slim chance, you could get an excess charge. That's when doc adds 15% to the bill. N does not cover excess, G does. And then G has no copays, only that B deductible once a year. N has 2 types of copays. N has a copay of $20 to see a doctor, a primary care doctor, a specialist. And then if you go to the emergency room on an N plan, you'd be responsible for a $50 copay. So again, they're very, very reasonable. And so people that are really maybe looking for something that's a little bit more budget friendly, maybe money's a little bit more tight, then N may be a good option. You're not taking on a whole lot of extra risk. Excess could happen, but it's still slim, and some copays that are still very reasonable. Those that say, that $30 or $40 a month is not going to make a big difference in my budget, I'll go ahead and get the most comprehensive plan available today. That would be G. Both are great. They really, really are. You can call in and we can see what the difference would be in your area, but now you understand kind of the difference of the coverage of those plans. All right. Here we go. Does any type of insurance contribute to the IRMAA?
Inheritance, not insurance.
Oh, inheritance. I'm sorry. My bad. Sorry about that. Okay. Does any type of inheritance contribute to the IRMAA? Well, I'm number one, I am not an accountant, okay? I am a financial advisor, so I'm pretty familiar with tax rules, but I'll say this to you. If that inheritance had to be recorded as, not recorded, reported as income on your tax return, meaning it was subject to taxes, then yes, it would count to the IRMAA, because everything that's considered to be income on the tax return goes into the AGI. So yes, but I think most inheritance money is not subject to taxes unless it's, huge amounts. But yeah, ask your accountant about that. But as a general rule, the answer to that would be no. All right, been trying to get CPAP supplies since September. Medicare requires a sleep study within 5 years. Wait time has been 5 to 6 months. Wow. Can I get reimbursed what I bought? Okay. Well, I don't know. I don't think so. Because you have to first prove that you qualified for the CPAP machine, because there has to be a prescription written for it. So the point is that prescription is written, let's say it's written today, or whatever, a month from now. You get a prescription in May for your CPAP machine, to get filled, and then you turn in a bill that was, 2 or 3 months earlier. I don't think they're going to reimburse you for that. I mean, that's just a bummer. I hate that this happened to you, but I don't think so. Just because I don't think they're going to pay for a bill that was paid prior to even you being approved for the CPAP machine. I tell you what you can do. Steve, I would call the CPAP company that you're going to use, the durable medical equipment provider, and ask them that question. Say, in this situation, what would you recommend? And you're probably not the first one that's had that problem, and see what they have to say, and hopefully they'll tell you the truth about it. But at my level, when my thinking, just common sense says, no, probably not going to get that covered, but they should know for sure, and hopefully they'll give you an honest answer about that. All right. Mark, what happens if I underestimate my projected income when filing an IRMAA reduction request? Do I have a chance to file a correction at the end of the year, or will I be penalized? Yeah. You will be able to correct that. And the way I would do that, and number one, try to project it well. But I know sometimes, especially if you're drawing off different assets, you're not for sure where it's going to be. But let me say it this way. Let's say that you put on your IRMAA appeal that you're going to make $97,000, and you're single. You're still below 106, and it comes up being at 105. Doesn't matter. So as long as you stay below that IRMAA level, either the whatever threshold you're going after, it's not going to be a problem. But if you said, I'm going to make 104, and you end up making 110, now you just got an IRMAA. So you would notify your local Social Security office, let them know that you did make above that amount, and then they can make the adjustment. And as long as you let them know of that in advance, or as soon as you know, I don't think there's any penalty for that. I've never had a client get back with me and say they were penalized for that. I've had people who've been in this situation where they underestimated, and so they did have the chance to make that correction. So I think as long as you do that, I think you're going to be fine. All right. But remember, again, let's say you estimate 60 and it ends up being 102. You're still below the IRMAA level. Don't worry about it. Only if we exceed that amount would I be concerned about notifying them. All right, Gwen. I've had 3 EOBs provided from my Medigap for Mutual of Omaha. When I add the Medicare paid $254 and Plan 64, it doesn't add up to the Medicare approved $324.59. Should I care? I wouldn't. Sometimes some of these explanation of benefits can be off a little bit. I would not go in, lose any sleep over that, as long as you don't have to pay anything. They're not asking you to pay anything above your B deductible if you have a G plan, or if you have an N plan. As long as you're not coming out of pocket, I would not worry about that at all. Now, if it was off $2,000, even though you don't have to pay it, then I would be suspect, somebody up to something, and then sometimes there's Medicare fraud going on. But here, we're just talking about a few dollars. I wouldn't lose any sleep over it. I wouldn't want to call Medicare and go on hold for 2 hours just to try to get that resolved. I'd probably just let that rest. All right, Scott, I have VA benefits, turned 65 in August. I retired early and live on Social Security. Should I still enroll for Medicare, et cetera? Well, Scott, technically, you can just use the VA if you're confident that you're going to be happy with the VA solely. You can get by with A only for sure. However, if the VA changed their system and now you want to pick up B at a later date, then you're still going to be subject to two rules. Number one, you'll only be able to add B at a later date during the general enrollment period. That's the first quarter of every year. First 3 months is it. And then for every year you went without Medicare Part B, so typically 65 on if you're no longer working, for every year, 12 months, full 12 months, you go without Part B, you're going to be assessed a 10% penalty for life. So let's say 3 years down the road, VA changed their system and you don't like it and you want to get back into Medicare, you can, first quarter of the year, but now you've got a 30% penalty added to your Part B lifetime. So that's really what you have to weigh out. Excuse me. I had a guy last night at a seminar that I spoke at in your exact position. Money was a little bit tight, and he had A only, and he's very, very happy with the VA. And so I told him, then stay right where you are. Just do A only. Do everything through the VA because he simply did not have the money for his Part B premium. Now, another thing you can do, Scott, is you can also apply for what is called a Medicare. Oh boy, it's basically extra help. They have two different programs. Medicare, I am blanking on the name, so it's bad about getting old. But they have a program where you apply for extra help, additional benefits, and if you qualify based upon your income and assets, Medicaid and Medicare will actually pay for your Part B premium for you. And then if you did that, if you could get that
Medicare savings
there we go, Medicare Savings Program. Boy, I just blanked on it. But apply for a Medicare Savings Program. You can do that through typically through state Medicaid offices as well as Social Security. And also you can apply for Medicaid if you wanted to, but they will oftentimes pay for Part B premium. And then what you could do is get a civilian option. You got your VA option, and then you could do what is called a dual SNP plan. That's a Medicare Advantage plan called Special Needs. So there's a lot of really nice benefits that come with those. So use the VA when it's in your best interest, and then you could use your Medicare Advantage dual SNP plan. Dual means dually eligible for Medicare and Medicaid. And they've got some nice perks in there for sure on those dual SNP plans. So that's what I would do. Apply for this Medicare Savings Program and extra help. And if you get that approved, that gives you a lot more options. Then you have the best of both worlds, really. All right, let's keep going. Rob, I'm covered by my MC Medicare, I guess, Advantage plan, but wish to back to traditional Medicare because Aricept is in my medical history. The Part B premium skyrockets. Yeah, it does. If I no longer take the drug, can the premium be lowered? Okay, well, here's the way that's going to work, Rob. Since Aricept is because of dementia, Alzheimer's, so if you can get a statement from a doctor saying that you do not have dementia or Alzheimer's, and either maybe that was just something that was, diagnosed, and I don't know, but I'm saying a doctor is going to have to verify that you no longer have that, because I can assure you, any underwriter that's going to see that in your prescription drug record, they are going to decline your application. Okay. So Part B premium skyrockets. And it's really not Part B premium. That doesn't skyrocket. Your Medicare supplemental premium would be what is going to be very expensive. Yeah, because Part B has nothing to do with medical condition at all. Only thing that makes Part B go up is IRMAA, high income. So it is true that your supplemental plan, and frankly, it's not about skyrocketing. I don't know of any carrier that would even take you. They won't even approve a policy with someone who has Aricept in their medical records. So I just don't think you can get approved. But if that was a misdiagnosis or something, and doctor will verify that and write a letter, then we probably can get an underwriter to take a look at that and maybe drop that off. And then you can get just a normal supplemental plan. All right. All right, when I retired at 65, what documentation do I need to have to show I had credible coverage? Well, Rhea, interestingly enough, you don't have to show any credible coverage if you're going to come into Medicare at 65. if we come into Medicare 65, 3 months before, a month up, or 3 months after our 65th birth month, credible coverage is not necessary. The only thing we have to do is we have to be turning 65, and we have to have 40 quarters paid into the Medicare tax system. If someone doesn't have their own 40, they can get from a spouse or an ex-spouse possibly. But the point is there's no credible coverage requirements at all. 40 quarters, turning 65, you qualify to enroll in Medicare during the initial enrollment period, 3 months before you turn 65, month of, and then 3 months after. Now, if I'm coming in after that period of time, then you better have credible coverage or you got real problems. But at 65, not required. All right, what's next? If someone has a Medicare Advantage as well as a group plan from their job, are they overcovered? Here's what happens. In that situation, the employer, if there's 20 employees on the payroll or more, then the employer plan is going to pay first, and then Medicare Advantage is going to pay second. So would I say that's having too much coverage? No, especially if there's very little premium associated with the Medicare Advantage plan. I don't think that's crazy. Now, if I had a good group plan, I see no reason in having the Advantage plan, but if you have it, I don't know why you do. If I had a good group plan, what I would do is if that group plan is going to continue on for a while, you know that you're going to work, or your spouse, whoever has it, is going to work for a couple more years, I would drop the Advantage plan and I would drop Part B, and I would have A only. That's what I would do. Now, if it's a lousy group plan, then don't do what I just said. But if it's a great group plan, great price, great coverage, low deductible, then I wouldn't have Medicare B. I would have A only and then pick up B at a later date. Now, the key to getting B at a later date is you have to have credible coverage through an employer plan, yours or your spouse's, back to 65 with no gaps at all. So I don't know your situation to tell you that, go out and drop Part B. But someone that has had continuous employment coverage with no gaps could do that. They could drop the B, get rid of the Advantage, and just be covered by the group plan, and then pick it up at a later date using what's called the special enrollment period. So more coverage you need? Not necessarily. That Advantage plan will coordinate with the group plan. That's the way it works.
So if you're dropping B, you can get out of that Advantage plan anytime.
Oh, once you drop Medicare B, you'll be automatically dropped from your Advantage plan because you drop B. B is going to notify that Advantage plan, and you just can't qualify. And you can't have an Advantage plan without having A and B. That's why. So it automatically drops it. All right, great question. Hope that made sense. That was, what was that comparison site? Oh yeah, there it is, medigapcompare.com. Medigapcompare.com. It's a great site. Good information. What else? Daniel's looking for a question that we haven't covered yet, so he'll find one. And folks, just remember, next week we're on for Wednesday. Yeah, next Wednesday at 5 o'clock Central Time. Again, usually I do them on Thursdays. Couldn't this time because I'm speaking. And then next week, I leave for Ireland on Thursday. So we're going to move it to Wednesday, 5 o'clock Central Time. Love to have you be a part of that. Any more questions, Daniel? Hang on just a second, folks. We'll have another one here soon. What happens is we get into this over an hour. A lot of these questions are very similar to ones I just had you had asked, and so he tries to find new questions, unique questions.
Okay, let's just
Okay, here we go. Diane, what is the benefit of an Advantage plan over different plans in GF, et cetera? Diane, really, there's only one benefit of an Advantage plan, and that is the monthly premium, and nothing else at all. Because right now in the market, 2 out of every 3 Advantage plans has a 0 premium monthly. Now, you still have to pay Medicare Part B, the $185 a month, or IRMAAs if you have those. But that's the only advantage, that low premium. Now, some would consider some of the perks as also an advantage, and I guess that's fair to say. The perks would be a gym membership, but the reality is less than 5% of all people use the Advantage Plan gym membership, so that didn't help many. And then they do throw in a dental allowance. The issue with that is a lot of them are preventive only this year. If they're not, sometimes you can't find a dentist that takes the plan. So these benefits are highly advertised, but also highly underutilized. So truly the main advantage is a zero premium. Some of the perks, could be nice. But what I emphasize is if someone can afford a supplemental plan N or G, you get a lot for your money. Right now, and again, this is just average, folks, and N plan is going to be in the neighborhood of 100, 110 a month, G plan 140, 150 a month. And some states are higher, I know that, but just average. But what do you get for that money monthly? You know what you get? You get this. You get the fact that you can go to any doctor that takes Medicare. That's wonderful. And if you have a serious health issue, you get cancer, you're going to care about that. You see, Advantage plans have always networks, HMOs, PPOs. Not all doctors are going to take them. And your primary care doctor may take it, but your dermatologist doesn't, or whoever. Meaning, just because one doc takes it doesn't mean they're all going to. So if we have someone that has 5 or 6 doctors, sometimes it's difficult to get all those doctors covered by one particular plan. At most, typically when we look at a market, at most folks, of all the doctors available, about half of them are going to take Advantage and the other half are not. And the half that do doesn't mean they all take the same plan. So that's the whole point. What are you getting when you pay a premium for a supplemental plan? You're getting the opportunity to go to any doctor as long as they take Medicare. Get this, 99% of non-pediatric doctors take Medicare. 99%. The 1% that don't, half of those are psychiatrists. So almost all doctors take Medicare. All hospitals do take Medicare. You don't have to worry about networks. Number 2, you realize that when you have an Advantage plan, you are going to have 70% of the services that you're going to need are going to have to be pre-approved before you get that service. Your doctor does not make the final decision on Advantage plans. The doctor recommends, the Advantage plan makes a final approval. And many times they say yes to what doctor recommends, but plenty of times they say no. There were over 3 million, I think there were 40 or almost 50 million pre-authorization requests last year in the Medicare Advantage plans. Almost 50 million, I think that's what it was. And about 4 million, about 10% got declined. You say, well, 9 and 10 got approved. That's true, but if you're that 1 of 10 that got declined, you're going to be troubled by that. I've had people that needed a knee replacement, and Advantage plan said, no, you're going to therapy for 6 months, and then we'll revisit whether you need a knee or not, a knee replacement. I've had people that needed full hip replacements. Advantage plan said, no, we'll pay for a rod, and that's it, not a full hip. So if you want to allow an insurance company to delay, to deny, and be involved in all that, then get an Advantage plan. I say that is a disadvantage. Networks, pre-authorizations, and then the policy, the permanency. Advantage plans are only 1 year at a time. That's it. They come and go. Companies come and go. You get a supplemental plan, you pay for it, but you have a lifetime policy. Can never be canceled or changed by the insurance company other than unless you don't pay the premium. Now, the rates go up. Folks, all rates go up. Advantage plan, it has a zero premium, but the rates still went up. You know why? Because the max out-of-pockets go up. The copays go up. So those plans change. So everything goes up because of medical inflation. So yes, supplemental plans are going to go up over time. But if you go to the right company, you pay attention to stability of rates long term, you should be pretty happy. So when people buy a supplemental plan, they're getting a lot for that. They're not just paying it and it's a waste of money. There's a reason that people do that. I'm 64, I'll be 65 in January. I'm going to get a supplemental plan. I just am. And I think those that can't afford a supplemental plan should get an Advantage plan. If you can't afford the premium, don't try to because you won't keep it. So let's find the very best Advantage plan we can. Just so you know, our practice, our company, we're very large all over the country. 75% of our clients have Advantage, 75%, have SUPs, and 25% have Advantage. 75-25, that's our practice. A lot of practices, 90% or 95% Advantage and 5% SUPs. Some companies don't even sell them. And the reason for that is because agents like Advantage plans. Insurance companies like Advantage plans because they make a boatload of money. Advantage plans pay us twice the commission, lifetime residuals. Supplemental plans pay us half, and we get paid 6 years residual. That's the way insurance works. It's residual income. I truly get 6 years of residual income on a supplemental plan, but I got to take care of you for the rest of your life. And so agents that care about people will talk about both. Agents that care about their commission are going to talk about one, and that's the Advantage plan. And sadly, a lot of people are in them, and they're healthy at 65. They get an Advantage plan, then their health changes, and all of a sudden now they find out really what kind of insurance they have, because you really don't know how good your insurance is until you need it. And so what's the advantage benefit? The premium only. That's it. Okay. So those of you who can afford a little extra, you get a lot of great benefits off a supplemental plan. Sure, you don't have any perks. You got to pay for your own gym membership, your own dental plan. I got that. But you have great, great quality insurance. Okay, let's keep going. All right, Joe, what is your opinion of an innovative G plan? 2870 could an excess charge be applied on an innovative G plan or in any N plan? Okay, well, first off, I think what you're talking about would be the high G plans that have the option to convert to a regular G or regular N plan after 2 or 3 years or something. I think that would be fine if you want to do that. We are not fans of high G plans because you normally have to medically qualify to get off of them. Now, you may be with a carrier that will waive that for the first couple years. So that's the only reason I'm not a fan of them. Most carriers don't offer that. You have to medically qualify to move from a high G to a regular G. And so if your health changed, now all of a sudden you're responsible for that deductible every year for the rest of your life. And so excess charges can occur if you're in a state. Now, folks, there's 8 states that don't allow excess. 42 states do. So if you're in a state that the excess can be charged, then you are still going to have to pay that 15% as well, because you have to pay the first $28.70 before that supplemental plan pays everything. Now, Medicare is still going to pay their part, but you're going to have to pay $28.70 before that supplemental plan pays anything. That's why they're giving you that reduced premium. All right, so if you decide to do that, hey, I'm not knocking you for that. I wouldn't do it, but I'm not saying that's crazy. We're all different. Every one of us watching today. We have different deductibles on our auto policies, our homeowners policies. We're just different. So if you're comfortable with that and you feel like it's the best for you, then do that. I wouldn't, but I don't think you're crazy for doing it. I really don't. It's just nothing that I would choose because of that additional risk that's involved. All right, let's keep going. Will Medicare Part A reimburse me for hospital stay related tests that I paid personally if my effective date was before the stay? Okay, I think so. Yeah, as long as your Part A date, so let's do it this way. Your Part A date was January 1, 2025, and you had something done January 2nd, 2025, and you paid for it, then I believe you're going to get reimbursed for that. So you want to make sure you have the proper forms, and what I would do is I would just call Medicare Direct, 1-800-MEDICARE, and tell them the situation and ask them how you can submit the forms. There's probably some type of a reimbursement form, but I can see no reason why you cannot get reimbursed for that at all. As long as your A date was effective prior to services, you should be just fine on that. All right, let's keep going. All right, with original Medicare, and I guess it's capers, I guess, supplemental to original PPO, do I need pre-approval? I have cancer and afraid to retire. As of now, employer's insurance works fine. Okay, boy, YK, I'm not tracking with your question. Okay, yeah. Well, hey, why don't you do this? Say it, ask it differently, please. I want to help you, but I don't understand exactly what you're saying. Let me say this though. As far as pre-approval, are you saying pre-approval to get a policy or pre-approval for services? You're going to have to give me more information.
Public employee retirement system is what it is.
Public.
CalPERS is what it is.
Oh. Okay, sorry about that. YK, I was not. So with original Medicare and supplemental to original PPO. That's what threw me off when you say PPO. That I don't get that. Do I need pre-approval? I have cancer and afraid to retire. So now employers insurance, we're fine.
So they're wondering if they go with original Medicare, are they going to need pre-approvals, or should they stay on their employer plan? Or stay with their government provided plan.
Okay, you can have original A and B and all your services are covered under those terms of A and B. So there's no declining of A and B because of any kind of a cancer type issue. Everything would be covered as soon as your A and B started. But A and B has gaps, financial gaps that are not going to be covered. So your employer, what I would do is I would call your CalPERS and ask them how they pay in coordination with Medicare A and B, because right now your employer is probably first payer, or this CalPERS plan is, I guess. But once you retire, then Medicare A and B is going to pay first, CalPERS is going to pay second. And so I think as long as you have that, as soon as you started your Medicare, you should have no pre-approval issues whatsoever. But I think you need to call CalPERS and ask them. And I'm sorry, I can't give you any further direction than that. All right. If I call Medicare School, can you help me assess the premium stability of different Medigap plans that I might switch to? Pricey regions in Seattle. Yes, yeah. And here's the problem, TH. We can't for sure. But Washington is one of those states that has an open year-round enrollment of switching Medigap policies. And that's what drives those prices up so much in Washington. It's a great consumer-friendly law, but financially it's just painful. But yes, call us and we can talk about the different carriers in Washington. There's not tons of them because of that law in Washington. But yeah, call us and we can take a look and see where it is and see if we can get you in a better position. Happy to help. All right, if someone has a MedSup plan and needs chemotherapy for cancer, is this covered with no copay or other payment? If there is, say, a 20% copay, which MA plans have? Is there an annual? Okay, let's go back though. Let's talk about the MedSup plan. It needs chemotherapy. So if you have a G plan and you're getting chemotherapy, there are no copays on a G plan. You have to meet the Medicare B deductible once a year. This year, that's $257. So all that cancer treatment, chemotherapy, radiation, whatever, on a G plan would cost you $257 for the whole year. You pay your premium to the G company, you're done. Okay, so that's how that works. Now you're saying if there is a 20% copay for chemotherapy, which is what Medicare Advantage plans do, is there a max? And the answer is yes. So chemotherapy oftentimes is 20% paid by you, 80% paid by the Medicare Advantage plan. But your out-of-pocket, which would be your 20% copay here, would go towards that annual max. Those vary. Right now, the average, I think, on HMOs is around $3,000 to $5,000 for the year. PPOs is going to be somewhere between $5,000 to $10,000 a year, depending upon if you're in or out of network. All right, so there is a max with all the Advantage plans. That's one of the rules the government said. When there's an Advantage plan, there has to be a max out-of-pocket, okay? Your max out-of-pocket on a G plan is going to be your premium and your once-a-year B deductible. So if you're ill, have health problems, that's going to be a whole lot lower than your max on your Advantage plan. Yeah, because people that get cancer, some serious health issues, almost always spend more on their Advantage plan max than they would have on their premiums on their supplemental plan. All right, a couple more questions, Daniels. I have an MA-only plan with FEHB as my supplement. Okay, good, got it. If I get a knee replacement or some other operation and my MA-only PPO plan says, no, we will not pay, will my FEHB pay the full amount? Wow. Okay, number one, I've never had that happen. Okay, so listen, the scenario that you have selected to have an MA-only plan with FEHB, that's done all the time. The issue would be FEHB is now going to coordinate with the MA-only plan. So if MA is saying no, I don't think your FEHB is going to say yes. And that's what people have to be aware of. So the question is, why would your MA only? Because it looks like to me, I think this is kind of hypothetical. Why would they say, no to that if you really needed it? And even if they put you through a pre-authorization and you got a decline, you can always appeal. Do you realize that 8 out of every 10 appeals get approved? These insurance companies are kind of rascals sometimes. So, and again, it happens. Hey, I've had it happen. I've had people, not get a knee replacement so that could happen. But I don't think FEHB is going to cover if the PPO plan did not. Okay, and you may need to ask FEHB. I've never had that happen yet in my career of 16 years in the business. Okay, so technically, I guess it could happen that you would FHB would, but I don't think they would. I just don't. I'm not sure of that, though. Sorry about that. It's a new one on me, Air Boss. Let's keep going.
I think you should respond to this.
Okay. Again, you are talking really bad about Medicare Advantage plans, and I have had the same one since 2016. Never had a problem with pre-authorizations ever. Maybe some carriers do. Well, then, number one, I'm glad you've had a good experience, and your situation can be multiplied, by hundreds of thousands of people, if not a few million people, for sure. I have clients on Advantage plans that are happy, but there are times when people are with an Advantage company that cares more about their profit than they do about the patient's care. And I've seen that time and time again. You can do lots of research on this. I don't make stuff up. People are oftentimes disappointed with what happens with networks and pre-authorizations. You've had a good experience, and I'm glad for you. I really mean that. But it is not abnormal for people to have some issues with Advantage plans. If they were great and perfect for everyone, then the government would not be cracking down on them so hard. You wouldn't see all the complaints you have and the lawsuits and those kinds of things. I've got a whole file of stories. I had one not long ago, a lady out of San Francisco whose husband was on an Advantage plan, and they sent him home from a skilled nursing facility prematurely. He wasn't ready to go home. Goes home, and he died. And she literally blames the Advantage company for his death. We had an agent here in our own business. His grandparents were on Advantage plans. Same situation. Grandma has a stroke in skilled nursing. Advantage plan said, you're done after 20 days. I sent her home. Grandpa's going to try to take care of her. He can't adequately do it. He just wasn't the right caregiver. He has a heart attack and dies. Okay, was that the Advantage company's fault? No. But should she have still been in the skilled nursing facility getting care? Yes. So why'd they send her home? Because they don't want to pay those bills. I'm telling you, post-acute care is one of the biggest places where we see Advantage plans abuse the system. Why? Because the algorithm, the computer system says, with this disease, you ought to be done in 16 days. This disease, 24 days. And if the computer says you should be done, they're going to stop paying, and then you got to leave that facility. Okay, so that's just the reality. But again, I'm glad it's worked for you. I hope it continues to work for you. Let's keep going.
Okay. We're at time. I don't have anything else.
Okay, very good, folks. Okay, well, I had to have a hard stop. I have to go speak at a workshop here before long, and so thanks for joining. And don't forget, next Wednesday, 5 o'clock, I'm leaving next Thursday for Ireland on vacation, so we'd love to have you join us next Wednesday, 5 o'clock. And do me a favor, if you're still with us, tell your friends. We would be delighted to serve as anyone's Medicare broker, and our YouTube channel. Keep getting educated, and appreciate your time. You have a good evening. Thanks.